for you that, thank you, Olivia. So we recognize that our work and the work of our members takes place on traditional Indigenous territories across Ontario. We also wish to acknowledge that the office of the RNAO is located on the traditional and unceded territory of the Huron-Wendat, Haudenosaunee, and the territory of the Mississaugas of the Credit. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, which is an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We also recognize that all of you are located on other traditional lands across Ontario, and today this land is still the home of many First Nations, Inuit, and Métis people from across Turtle Island, and we're grateful to have the opportunity to work on this territory. And by personally making a land acknowledgement, we're taking part in an act of reconciliation, honoring the land and Indigenous heritage, which dates back to over 10,000 years. And we encourage you to learn about the land you reside on and the treaties that are attached to it as one small act of reconciliation that we can participate in. And as we enter this topic today, I'm thinking that we might want to keep in our minds how the residential school system and other forms of systemic injustices have disproportionately affected Indigenous people across Turtle Island, and just be thinking about that through our discussion today. So this webinar is being recorded, and we do intend to post this publicly on our website for anyone who has missed the webinar and wants to watch it or share it with others. However, what we have noticed in the past is sometimes we have decided not to post a webinar in case some of the content becomes really sensitive. So there could be decision afterwards to only share a part of it, or not share it at all. But the plan right now is to record it and share it if we can. So this is the overview of our plan today. And my name is Susan McNeil. I'm the Associate Director with Implementation of Guidelines at RNAO. And warm welcome to all of you today. In just a moment, Matt Kelway, our Director of Nursing and Health Policy at RNAO, is going to provide an overview of the issues, touching on the overdose crisis and toxic drug supply and the rationale behind decriminalization and harm reduction. Then the bulk of this session today is focused on our wonderful panel. So thank you all panelists. I'm going to share their bios in just a moment so you can hear more about them, and then we'll have each of them have an opportunity to speak about this issue from different perspectives. Then Sabrina Morali, who's our Manager of Mental Health and Addiction Program at RNAO, is going to moderate the questions and answer period, and also just share a little bit about what we offer at RNAO in our program. And Matt, I think, is going to talk a little bit earlier and then maybe a bit later again about the Decriminalization Now campaign that we hope you will participate in between now and the municipal elections next week. And the other thing that I wanted to just say about the connection of this webinar to the topic, this is part of the Health System Transformation webinar series, and kind of making a link between this topic and this series. That overdose from the toxic drug supply, it really is a public health crisis. And at RNAO, we consider the response to the public health crisis to be insufficient, and it has resulted in thousands of preventable deaths and hospitalizations and emergency room visits. So this is a huge stress on our health system, which is already, as you know, overburdened and already in crisis. So we just wanted to kind of help you see the connection between the topic and this webinar series. Now what I would like to do is introduce you to our panel, and I'm going to read their bios, and thank you once again, all panel members for joining us today. So Cori Chapman is a retired nurse, mother, grandmother, and great-grandmother. She has worked in hospitals for her entire career, starting in the operating room at the University of Alberta Hospital and then at Toronto Western Hospital. She was hired prior to opening of the Credit Valley Hospital in Mississauga as the head nurse for the operating room. And over the course of her 23 years plus at CVH, she moved to a director position and had the responsibility for a variety of clinical programs. This past August marks 7 years since the death of her oldest son, Bradley John Chapman, who died after an overdose of toxic drugs. Memories of Brad are still with her always and leave her broken on many days still. Kathy Moreland has been a registered nurse for 40 years in Ontario and Michigan. She has been a RNAO member since 1986 and was awarded the Lifetime Achievement Award in 2016. Among her professional accomplishments include 22 years in oncology and palliative care as a staff nurse, educator, manager, and acute care nurse practitioner, and 18 years as a full-time professor of nursing. She was also very involved in complementary therapies and is a retiring Healing Touch certified practitioner and instructor. Over the past 10 years, Kathy has participated in MPP presentations on behalf of RNAO. She gained approval of 2 AGM co-authored resolutions, the first on fetal alcohol spectrum disorder in 2012, and the second in 2021 on the need for an integrated strategy to address the opioid crisis. Kathy recently retired and is now the president of Waterloo chapter and an active member of Mums Stop the Harm, advocating for drug policy change. She is known for her belief in and passion for nursing and can often be found inspiring RNAO members through dance and her positive tweets. She says, "Where there is a will and a nurse, there is a way." Sandra Ka Hon Chu is a lawyer and co-executive director of the HIV Legal Network, where she works on HIV-related human rights issues concerning drug policy, prisons, sex work, women, and immigration. She has helped guide the legal network's litigation on key court cases in Canada and internationally, including lawsuits challenging the Canadian government's failure to adopt prison-based needle and syringe programs and criminal laws governing sex work. Mish Waraksa is a nurse practitioner and clinical lead for the Parkdale Queen West Safer Opioid Supply Program, a Health Canada funded program for people at high risk of harm from the toxic, unregulated drug supply. Mish is a consultant for the National Safer Opioid Supply Community of Practice, providing support to clinicians new to safer supply practice. Mish has a passion for creating transformative healthcare programs for people who are alienated by our healthcare system and strives to provide client-centered care for people who use drugs. Emily Frenette is a primary healthcare nurse practitioner who graduated from Toronto Metropolitan University's PCHNP and MN program in 2020. Emily has been an RN since 2008, and she started her career in Montreal and has been working in the community since 2012. While working as an RN on the Montreal ACT team for the At Home Project, a project looking at the Housing First model, she realized how integral advocating for folks who live with substance use disorder is to their healthcare journey. Emily worked at Cactus Montreal, a needle exchange, leading an outreach sexual health clinic for people who use drugs. Since coming to Toronto, Emily has worked in harm reduction at Toronto Public Health's The Works, as well as ICHA, the COVID Recovery Hotel, and as an MRP at Inner City Family Health Team. Emily is now the NP and supervisor of Toronto Public Health's injectable opioid agonist therapy program. In this role, Emily prescribes both traditional opioid agonist therapies and injectable opioid agonist therapies, as well as supporting clients with substance use management and accessing primary health care or primary care. So that's an introduction to our 5 panelists here with us today. And before we hear from each of the panelists, I'm going to turn things over to Matt to provide us some background information about this topic.
Thanks a lot, Susan. My name is Matthew Coe. I'm the Director of Policy for RNAO. And just before we hear from our panelists, I wanted to provide a bit of context for their remarks in support of decriminalization. That context is really about the number of lives lost to this crisis. It's a crisis that's been with us for a couple of decades and has always warranted a fulsome harm reduction response. But there's a particular and growing urgency to the crisis now, as we've witnessed an alarming escalation of emergency room visits, as you see in the slide on the right-hand side there, hospitalizations and deaths. You can see in that bar graph on the left, the escalation of this crisis from 2.4 deaths per day across the province in 2016 to essentially 8 in 2021. The pandemic has fueled this escalation with an 85% increase in the average number of deaths per day from 2019 to 2021. Susan, if you could advance, please. Thank you. On this next slide, you can see some preliminary 2022 data provided by the Office of the Chief Coroner. It shows a slightly lower level of deaths through the first 6 months of 2022, but nothing to suggest at all that this is a crisis that's abating. The next slide, please, Susan. The personal stories that you'll hear today from Cori and Kathy take place in urban contexts, Toronto and Waterloo, respectively. And the nurses you'll hear from today practice in Toronto. But we wanted to show this map to make the point that this crisis is by no means an urban crisis. In terms of per capita overdose deaths, you can see that Northern Ontario is in the highest quintile, but so is the Niagara Peninsula. On the other hand, you have a remote location like Temiskaming in the lowest quintile. Meanwhile, Ottawa Public Health is in the second quintile. Toronto sits in the middle. In other words, this isn't a remote, rural, or urban crisis. It is all of the above, a provincial crisis, and indeed with over 30,000 deaths across the country due to opioid-related overdose since 2016. It's a national crisis. You'll hear a bit about that from Sandra. So this is what motivates RNAO's political action on this issue and its call for decriminalization. And I just wanted to mention by showing the next slide that we are just at the end today of our Decriminalize Now campaign, whereby we asked candidates for mayor in 22 municipalities across the province to sign a pledge that if elected, they would put forward a motion to their municipal council requesting that the federal government decriminalize simple possession within the municipal boundaries. That campaign closes today, and we look forward over the next couple of days to identifying for the membership and the public which candidates support decriminalization. But first, let's get to our panelists. I've talked about the numbers, but Cori Chapman and then Kathy Moreland, both RNs, are going to humanize those numbers with stories of their sons, Brad and Austin, both of whom lost their lives to overdose. No single story can represent fully this crisis, nor can two stories even, but these two stories will give you a better understanding of who can be touched by this crisis and how decriminalization might have intersected with their lives and experiences. And Cori, you're up first, and we've never met. It's such a pleasure to meet you. I've met your daughter. We worked briefly together at ICHA, and your daughter now the National Chief Nursing Officer for Canada. That must make you tremendously proud. I know I'm proud to know Lee, but I want you to know that Brad is woven into the work that we do at RNAO on this issue every day. And so it's delightful to have you here with us today to share your story. And let me turn it over to you to do that. But thanks. I think you're on mute, Cori.
There we go. Thank you, Matthew, and thank you for this, including me in this important work that RNAO has embarked upon. I'm just going to tell my story it's actually Brad's story. I just had to pull it up here so I don't lose track of my. Brad was adopted in 1972 when he was 9 months old, and he was followed by 2 biological children. So we had 3 children, and this first beautiful baby boy brought so much love and joy to our lives and our wonderful community that we were living in at the time in Etobicoke. Brad was involved in we were all involved in a lot of community activities, and he was in the first French immersion class. He took Royal Conservatory piano lessons. He loved sports and was good at sports. We had trips and camping trips and many summers in Alberta visiting with family and friends. But he started to have problems in school. He was hyperactive with learning problems, which is what they attributed to in those days, but very little help. And he scored high on his IQ tests and other standardized tests. So it was really kind of seen as a behavior problem, acting out. In today's world, he probably would have been more accurately diagnosed, but at that time, we sought help for him wherever we could, through the family doctor, through the hyperactivity clinic at Sick Kids. He was prescribed Ritalin for a period of time. We had a tutor for him, but his journey into adolescence then became even more difficult. There was a family breakup. My husband left when Brad was 12, and he was then often absent from school and acting out the trauma that we were all feeling as a family with the breakup. He had some run-ins with the law as a youth, and he spent some time in a youth group home that was a terrible experience, and he actually ran away from that. He was in a program called Logan, which is a residential program for a year, which I think was helpful. They look after children with or youth who have emotional, social, and psychological problems. And he was able to continue to his school and receive counseling there. He eventually met a young girl, Janet, and they lived with her parents in the east end of the city. She was 15 and Brad was 20 in 1991 when they had their first child. They had 2 more after that, and they eventually moved to Midland to be close, to get out of the city. I think they were seeking a quieter lifestyle. They moved with Janet's parents. During this time, Brad had very sporadic employment. He worked in roofing, a little bit of electrical work that he was helping somebody with. He hoped to apprentice as an electrician, but really it was sporadic and part-time. And they were 2 young parents living in poverty on social assistance with very few resources and supports. And his relationship with Janet deteriorated, became difficult, and they eventually separated. He also had a fall during this time, and it resulted in a back injury, and he was prescribed MS Contin. And I believe he was also dabbling in illicit drugs at the time and probably misusing the MS Contin. Later, this experience with prescribed and illicit drugs was even more complicated by a 2-year period when they were trying to make a diagnosis, which eventually led to the diagnosis of a brain tumor. And so after successful surgery, he tried to get off the drugs that he had initially been prescribed. And he was successful in getting off morphine, which was on his own, which was very difficult, but there was limited success. And he came back and lived with me off and on occasion, and we sought help for his post-surgical pain and for his addiction in the best way that we could. I had some contacts through my work at the hospital, and I contact CAMH and other providers to see what I could do, but there was very little advice, and there certainly weren't any there wasn't a lot of help. And not surprisingly, he was in a methadone program for a period of time, but he ended up going back to using street drugs. And then I tried to help as much as I could. Mostly I helped with his 3 children, but I was always there for Brad and answered his phone calls and met him whenever I could and tried to help. Then on August the 15th, 2015, so that's over 7 years ago, I got a phone call. I came home and there was a voicemail from Dr. Granton in the ICU at TGH who said, Brad was in the ICU and they were ready to withdraw life support and we needed to get down there. So I went down immediately. My son and daughter, who were in different parts of the country, with some difficulty, organized things for themselves to get there, and also for Brad's 3 children, who also were in 3 different parts of the province at that time. But we all managed to gather by noon the next day, and the hospital explained that Brad had suffered a catastrophic brain injury from an unwitnessed overdose, and that they were ready to withdraw life support. And that they had been trying since admission to identify Brad, but they had just traced me as the contact on that day that they called me, so a week later. So we were all there, along with a cousin of mine who lived in the city, and gathered around the bedside and ready to withdraw life support. They commented, the hospital and physician staff were amazing and respectful and compassionate and really heroic in their efforts to initially resuscitate Brad until they realized the extent of the brain injury with the CT scan. And they commented that the John Doe they had been looking after for a week actually had this loving family gathered around him that day. And we were just so grateful to be there. And it would have been so difficult to have missed the last day of his life. And we really have to thank the hospital team. It was the chaplain who did some sleuthing and was eventually able to uncover his identity and called me sort of at the 11th hour, so to speak. But in fact, Brad did have ID with him. It was in a backpack that accompanied him, and it was found on the street with him. The police took it away, didn't log the belongings, didn't think it was important that he be identified, or at least didn't make the effort. And they said it was because their supervisor was away and it was their end of their shift, and it just didn't happen. The supervisor, a detective who returned a few days later when I contacted him, said, well, you would have been notified post-mortem, which to me indicated, along with other things, the whole attitude about this man they had found on the streets. And in fact, there were other issues. The first aid response was very inadequate. The police officers explained that they didn't really know that there was an opioid crisis at the time. Didn't know anything about fentanyl contaminating the drug supply on the street. I had been reading about it coming from the West, and was not surprised that, in fact, one of the questions I asked Dr. Granton was this fentanyl? And indeed there was fentanyl. However, those issues persisted then after Brad's death, and we started to investigate, well, first of all, why he wasn't identified, and the backpack that he had with him, the police destroyed 2 or 3 months later, even though at that point in time they knew that Brad had family. Just a minute, I'm going to get back to my notes here so I don't go off track. A few other things that were concerning. When Brad was in jail that last time, which was about 6 weeks before he died, when he was released, he had made very concerted efforts to get, as he did often when he was in jail, it was time to recalibrate. And he was in jail for things like stealing a liquor bottle or nothing violent and nothing. In fact, it was often a time for him, I think, where he felt he could get healthy and eat better and had housing of some sort. And he made an effort with the St. John Howard Society. He met with the chaplain, met with the social worker, and he really wanted to have help when he was discharged. However, he was discharged to the streets with no help. Token appointment with his probation officer, which actually didn't even happen as it was supposed to once he was released. They put it off until the end of August, and by then Brad was dead. So these outstanding issues, the transition service, the police response, their inadequacy in terms of the first aid response, were things that we then lobbied with we felt needed further investigating. The other, just aside, was that at that time, Brad was on the street. Nobody was counting homeless deaths in Toronto. So my daughter and Kathy Crow, of course, some of you know her, and a few other people lobbied the city of Toronto to start counting the number of people who were dying on the streets, so that at least, and the reasons why, and it could help with the solution, one would think. So that did happen. We went through a 4-week inquest, which was quite grueling, but also very revealing, and ended up with 54 recommendations, which was really sort of heartwarming to see some good come out of the situation we were experiencing. However, in the end, of course, nothing could bring Brad back, and we're still grieving. And so that's my story. I'd be happy to answer any questions. I think that comes at the end.
Yeah, thank you so much, Cori. I'm looking at the picture of Brad, proud dad, and his 3 young ones there, and it's such a difficult story to tell. I can only imagine, and we really appreciate you doing so today, and we really appreciate your efforts after Brad's death to change things. And for those of you who live or work in downtown Toronto, you can go to the Homelessness Memorial,
Yes.
Trinity Church in Trinity Square, just outside the Eaton Center, second Tuesday of every month, where good folks honor and respect the death of those on the streets who have passed away over the previous month. So please stay with us, Cori, for some questions, hopefully later on. But I'm going to hand it over to Kathy Moreland to tell her story. And Kathy, I read an article, it was strangely a BBC article about this crisis in the US and how it's affecting a new demographic, the teenager. And that's a story that you'll know well from your own experience. And let me turn it over to you to tell us about Austin.
Thanks for having me, everybody. And Cori, thanks for telling your story. It's not easy to tell our stories, but we do it for the legacy of our children. And what I think is ironic is, Cori, you and I have in common is that both our sons were adopted. And Austin was adopted at age 1. And I just have to correct the slide. His name was Austin Late. I went back to my maiden name, so it's Layte. And Austin came to me through adoption at age 1. Very exciting, energetic, delightful young man with eyebrows that most women would kill for, and the deepest brown eyes you've ever seen. He and his sister came to me when they were age 1 and 3. So my life changed drastically on that day. It became quite obvious in Austin's childhood that although he met most of his developmental milestones, that he had mental health issues and a lot of anxiety that caused acting out in school. And so through a lot of processes of assessment, et cetera, it was determined, and through the admission of his birth mother, that she had drank quite heavily through that pregnancy. And it became obvious that Austin and his sister had fetal alcohol spectrum disorder. And just for the nurses on the group, 85 to 90% of children who have, it's LAYTE, sorry. That most children with FASD, prenatal alcohol exposure, 85 to 90% of them will experience mental health issues. And so Austin certainly fit that picture, although he did not have any of the facial features, and he was articulate and in the 95th percentile for intelligence. He was an excellent athlete. He was an excellent musician. He was amazing with building things, including like woodwork and metalwork. But it was challenging being his mom, even as a nurse, and knowing how to negotiate and navigate the healthcare system. It was still very, very difficult. Thanks for correcting it with an E on the end. We'll get it right eventually. Susan, it's okay. I just want to make sure his name is correct. So Austin ended up having to go into special schools. Classrooms, because he was easily triggered and could become aggressive, and therefore throughout his early teens and youth he was in a specialized classroom for FASD, which were developed as a result of advocacy in our community. And during his initial classroom, his first classroom in high school, the high school classroom, he was introduced to a classmate who introduced him to people who used meth. And this is when our roller coaster, and Cori could probably understand this, it's just a roller coaster of fear and anxiety beyond anything I've ever experienced as a parent or nurse, of trying to find the right services and help for Austin, knowing full well that there's a poison drug supply out there. So Austin's experience with fentanyl came about, and we had frank conversations about it, because the first thing I got told as a parent was kick him out, because he has to hit bottom in order for him to get better. And I think what I want everyone on this webinar to know is hitting bottom now means death. The drug supply is so poisonous that anyone exposed to illicit drugs could die. And a number of the deaths that Matt reported earlier are of students who decide that they need a Xanax off the street, or they need a lorazepam, or someone tells them at a party, look, I've got this Percocet, and it's not Percocet, it's fentanyl laced illicit drug. And so this isn't about just young people and young adults that you see struggling on the street. This is happening to young people who are trying for the very first time, and adults that are trying for the very first time, trying to cope with the stresses of life. And we don't have to experience that although we know that alcohol still is the number one substance that kills people, it doesn't kill people instantly usually. And this is what the difference is. Anyway, I digress a little bit. So Austin got introduced to fentanyl when his dealer told him he didn't have any meth, but you should try this, but I'll make sure you know not to take more than you should. And when I realized that Austin was using fentanyl, because all through this time we were trying to get him help, and I have to say that he was denied residential treatment when he wanted it because of his FASD. 4 major treatment centers in our province denied him treatment because he had fetal alcohol spectrum disorder. And the quote was, they don't do well in our programs. So even when Austin wanted help, he could not get help. I formed him a couple of times because while he was on meth, he threatened to kill himself. He threatened to kill other people. I was treated like absolute pariah in the emergency department, I hate to say, because I knew he was withdrawing off meth, and they had me sitting with him, and the nurses told me I was agitating him. And I walked to them and I said, I am truly trying to prevent him from hurting one of the other patients you have him sitting next to because he was so agitated. The police had left and the security guard kept getting called away when I had him in the emergency room, when I had him, when I had to form him, which is not anything I would wish on anybody. To try to, we didn't have to deal with as many years of fear as you did, Cori, and my heart goes out to you for that. Austin's drug use happened over a period of 2.5 years. And as I said, when I found out he was using fentanyl, it was when he went into withdrawal. He had gotten sores on his legs and couldn't go out. And I watched him going into withdrawal. And I said, what is it that you've been using? I need to know, because I didn't want to know, but I needed to know. And when he told me, I said, you're playing Russian roulette. And he said, don't worry, Mom. My dealer told me that he would never give me any drugs that would hurt me. And he says, I know my limit and I stay within it. So actually, if we fast forward to COVID, there was, I have to tell you that the shelter system for my son was just a breeding ground of more crime and more drug use. He was propositioned by dealers and told they would protect him and give him drugs if he did things for them. Decriminalization to me is an important part of an integrated drug harm reduction strategy, because Austin did get arrested. He was never arrested for possession, but had he been arrested for possession, I think it would, and he had survived, it would have affected the rest of his life because of the criminal record he would have had. And he probably wouldn't have been able to do any of the things that I hoped he would be able to do had he lived. But getting back to his story, he used fentanyl for probably 6 months. And that was 3 months before COVID started. And actually COVID was a good thing for us because he had to stay home. He had to stay home. And so during that time, he would go out, and I realize now that when he would sneak out at night, it was because he was smart. He wouldn't use alone. He used our CTS here in Kitchener frequently, unbeknownst to me, but I know that now in hindsight. And he really wanted to stop using fentanyl, and he had to do that on his own. So he was using weed and trying to use other things. I guess he even went back to meth for a while, but he was trying to stop using fentanyl. And the night he died, because he actually kind of died twice. The night he died, he was home. He had just graduated from high school that morning. They had done a drive-by high school graduation. And he and his girlfriend, I think, decided to celebrate his graduation. We had a pizza. He was the happiest I probably have ever seen him in his teen years. He was proud of himself because he had not used fentanyl for over a month. And I think that's what actually killed him, is because he underestimated how his tolerance would be. And the following morning, his girlfriend ran upstairs and said to me, Austin's not breathing. And I went downstairs to find him vital signs absent. And it was obvious to me that he'd been down for a while. Miraculously, he was resuscitated by the paramedics. And for 2 days, we were able to say goodbye, because he really never, his brain injury was so significant. And unfortunately, his 16-year-old, so he was 18 years old on the day, he had just turned 18. And unfortunately, 2 weeks later, his 16-year-old girlfriend also succumbed to a carfentanil overdose. And so I know there's at least one mom on here who's a nurse who is also a member of Mom Stop the Harm. So my work now in how I take care of my son is to advocate strongly for no other mother to have to go through this. We talk about the deaths and we talk about the hospital visits and how much that costs, and the cost to our criminal justice system for these drugs. But I don't think we talk about what it does to their families. I'm not the same person I was. I'm sure, Cori, you're not. I didn't think I would cry because I can shift into my nurse mode, but we are not the same people after this happens. And we are nurses and we couldn't stop it. So I only think about moms who are struggling, you know, who are also marginalized, trying to get help. I know the system and I couldn't get help. And it's just, I think nurses need to understand that, and they need to fight hard for all the pillars of harm reduction, including decriminalization, CTS's safe supply, prevention would be nice, like providing homes. All of those things would be really, really, are really important things for us to advocate for. Before I finish my story and kind of wipe out my tears, I just want to acknowledge the work of 3 other nurses in our organization who are doing a lot towards this and who aren't here today. And that includes Louise White, who was the original author of the decriminalization resolution in 2021, and Matthew McGuigan, who is also fighting for safe supply, and Christina Hughes, who co-authored the resolution with me last year. Austin, as you can see, this picture was taken about 2 months before he died. He had just been accepted back into his, he was going to become a welder. And he was really excited about that. So I comfort myself with knowing my son probably died on the happiest day of his life. And no parent should have to go through this. So thank you.
Thank you, Kathy, and thank you, Cori, for telling us those difficult stories. There's an element of guilt in asking you both to come to a webinar like this and replay these
Don't
stories.
feel guilty.
Well,
guilt is a useless emotion. Parents of people
well,
who lost
maybe
their
it is,
children know that.
Maybe it is, Kathy, but I can feel. I mean, I see your tears, and I can feel. Even over a Zoom meeting, I can get some sense of the pain that's still with both of you, and so we appreciate you sharing that. I think it's so important that we don't just show bar graphs and line graphs and talk in abstract terms about the crisis, but talk about the people, and so thank you both very much. I want to turn to
Matt. I just want to add one quick thing is I think, and Cori would probably agree with me, is that one of the things we don't talk enough about is the stigma associated with substance use. And I have no problem sharing Austin's story because I'm extremely proud of him. And I can tell Cori is extremely proud of Brad as well. And that their stories have to be told, that they have to know that there's a person behind the substance use and the behaviors that go with it. So all the people that are on this webinar need to know that there's a person behind those behaviors that we struggle with, and a family that loves them very much, most of the time.
Yeah, thank you so much, Kathy. I think this issue of stigma is critical to our advocacy for decriminalization, and I think we'll hear about that and how it impacts clinical practice from Emily and Mish a little later on. Right now, I want to turn to Sandra, co-ED of the HIV Legal Clinic, to provide us with a rationale from the perspective of her organization for decriminalization. Sandra and Janet, her co-ED, are remarkable advocates on this issue of decriminalization and harm reduction generally. They're great partners to us at RNAO, and we've worked closely with them on things like needle exchange in prisons. And they're a constant policy touchstone for me and for the folks in our policy department on these issues. So Sandra, I know you've squeezed us in today. You've got to leave us a bit early, but really appreciate you spending some time with us. And let me turn it over to you, please.
Matthew, and thank you so much, Cori and Kathy, for sharing your stories. They're heartbreaking, but I think it really grounds, like what Matt said, some of the more abstract concepts I'm going to talk about now, which includes some numbers about the harms of criminalization, which is the clearest, in my mind, the clearest manifestation of stigma is criminalization, and we really need to stop. So I have some slides here that I'll just share my screen. So this is what I call a drug policy crisis, because I think it's not only a toxic drug supply crisis or an overdose crisis, it's a drug policy crisis, because we have been waging a war on people who use drugs for more than a century, and it's clearly not working. It's fueling stigma and driving people away from healthcare. And so I think we need to do better. And I'm really so thrilled that the RNO is taking this up with this campaign. So just a little breakdown of the law in Canada. The Controlled Drugs and Substances Act, as you probably all know, is a federal legislation. That means that it's pan-Canadian. All of the provinces and territories are covered by this legislation, and possession for personal use is criminalized under Section 4 of this legislation. That means what we normally call simple drug possession. Trafficking in a substance is criminalized under Section 5. And so you're either trafficking, you're actually caught in the act of selling, administering, carrying the drug, or you're possessing for the purpose of trafficking. Usually law enforcement and courts will say the distinction, they'll look to evidence of things like multiple baggies, cash, scales, things like that, that might suggest intent to traffic, so not only using for personal use. In this legislation, there's also a section called Section 56, which I'm sure many of you know is the exemption section that for public health or medical purpose, anybody or class of persons can be exempted from any section of this legislation. So that's how supervised consumption services operate, because otherwise people in a CTS would be caught under these provisions. But because of the Section 56.1 exemption, then people are immune from prosecution in the context of a CTS. So some statistics here, oops. Even though cannabis was legalized, I think a lot of people have this misconception that there's not a lot of people being arrested, but post-Cannabis Act legalization, between 2019 and 2021, there are almost 200,000 arrests for drug offenses, and close to half of them were for simple drug possession. And we constantly hear, I know in the context of my work, I hear from a lot of police forces across Canada that they're not arresting for simple drug possession anymore, but that's simply not true, because we're seeing this in the numbers, and this is from the latest Jurastat, the Statistics Canada report. And in last year alone, there was almost 62,000 arrests, drug arrests in Canada, and almost half of them were for simple drug possession. So we know that the war on drugs is not waged evenly across communities, and we know that especially Black and Indigenous communities are disproportionately prosecuted, incarcerated for drug offenses. So we know in the city of Toronto, for instance, that this is the result of an access to information request I filed 2 years ago. 15,000 plus people were arrested for simple drug possession over a 5-year period. And even though Black people in Toronto comprise less than 10% of the city's population, when I was crunching the numbers, they accounted for 35% of those arrested. And we know that from the Toronto Star has done some great reporting about this a few years ago, but it's still happening. Like, this is the troubling part. In 2020, the latest numbers that they shared with us, this is still happening. I know a number of other people who filed freedom of information requests show that in Vancouver, for instance, Black and Indigenous people are dramatically overrepresented in drug charges. You can see these numbers, I won't read them out. And you see that manifest in prison as well. So in the federal prison system where people serve a sentence of 2+ years, 20% of the federal prisoners who are Black are there for a drug offense. And this is really, really, really high for Black women. More than half of Black women in federal prison, according to the Office of the Correctional Investigator, were serving a sentence for drug offenses. Often they're for import offenses. People are bringing drugs into the country, often people who are doing in situations of poverty. There was a recent case involving an Indigenous woman that is going to the Supreme Court, went to the Supreme Court of Canada, and she was doing it to avoid eviction. She was importing drugs. And so white women are also women are more likely than men to be sentenced for a drug offense in a federal prison system, but Indigenous and Black people are even more likely than white women to be in prison for that reason. So you see how the drug war is, not everyone carries that burden evenly in Canada. And so I think most of you also know this, that the health authorities across Canada, a number of them have come out in support of drug decriminalization. Our chief public health officer hasn't gone so far, but she's mentioned moving towards a societal discussion on decriminalization about 2 years ago. But you see, a number of health authorities, including in a number of them in Ontario, who have come out in support. There was a federal expert task force on substance use that was struck a couple of years ago, and they came out with 2 reports. One of them was on recommending alternatives to criminal penalties for simple possession of controlled substances. And they also recommended that all of drug control be brought under a single public health legal framework. rather than having Controlled Drugs and Substances Act, other, the Food and Drugs Act, bringing them all under public health legal framework versus a criminal legal framework. So that was one of the recommendations that came out almost a year and a half ago now. And as far as I know, not much has been done to actually execute these recommendations, which is in the context of crisis is really troubling. And also in the context of what a number of different organizations are doing, the Legal Network, along with a number of civil society organizations, said we wanted to create our own civil society vision of what drug decrim looked like. And this was led by, in partnership and collaboration with people who use drugs, including the Canadian Association of People Who Use Drugs. And that vision of drug decriminalization goes beyond repealing Section 4, the CDSA, which I mentioned earlier is a simple drug possession offense, but going beyond that, including Section 5 to permit what they call necessity trafficking. And that's because many people who use drugs also sell drugs to support their own use. Many people who are dependent on drugs, they might be selling drugs to provide a safe supply to their friends and colleagues or to support personal drug use costs. And we argue that it's not a good use of the criminal legal system to criminalize people who actually need supports. And they're often they're not a binary. People use drugs, also many of them also sell drugs. And we said not only removing the criminal legal sanctions, but any other administrative penalties. And we know in other contexts where people have said we've decriminalized, there's still penalization. So you can be tickets or fines, a mandatory health assessment, people can have their substances confiscated, or other coercive alternatives. So what we're recommending in this civil society platform is removing all sanctions and treatment if it is necessary, that be completely voluntary. And this is how would we get there? So there's two ways that I want to just touch on quickly. There's what we call de facto decriminalization, which isn't an actual change in the law, but we've seen that in different contexts around the globe. So, during the COVID pandemic, some US cities and states said they were just not going to enforce drug laws during the pandemic. So they imposed a moratorium. And we saw that in some US states. There's something called partial decriminalization in most provinces with a directive or legislation, which I'll touch on a bit later. I know the Legal Network and others have been asking the health minister to issue a nationwide Section 56 exemption from Section 4 of the CDSA in the public interest. And that's where you use Section 56 as a tool and just say across the country, if the health minister doesn't, or the associate minister of addiction and mental health doesn't want to go so far as to pass legislation, they could do this fairly quickly on their own if they had the political will, just a nationwide Section 56 exemption, or local jurisdictions, municipalities, provinces could request a Section 56 exemption. So the directive I just mentioned is one de facto way of decriminalizing, and they passed this, they created this directive in August 2020. So the PPSC is a Public Prosecution Service of Canada. So this is the body that's responsible for prosecuting federal drug offenses. And they do that across the country, except for New Brunswick and Quebec. So when I said most of Canada, it's almost most of Canada, except for New Brunswick and Quebec. So they came out with this directive almost 2 years ago now, which says that prosecutors should only focus on the most, quote, serious cases raising public safety concerns for prosecution, and otherwise pursue suitable alternative measures and diversion from the criminal justice system. Part of this directive, they also said, was that recognizing that criminal sanctions have a limited effectiveness as a deterrent. And so what are those most serious cases? They talk about any simple possession involving children in the context of a penitentiary, if you're engaged in another offense, another criminal offense, if you're in the context of some power relationship. So there's a few different criteria they show, and we see the results of this. This came out of a CBC News story about a year ago, and they saw that in Ontario, despite the police laying charges, the prosecutors have withdrawn or stayed 85% of drug possession charges in the system before they ever reach trial. And I heard this actually in the context of some Senate testimony around Bill C-5, which I'll touch on a bit later, that's not just in Ontario, that's consistent across the country, that prosecutors, the police are laying the charges, but because of this directive that came out in August 2020, prosecutors are withdrawing them. And that's quite a difference from prior to 2019 when you said there were only 45% of such charges were dropped. This doesn't actually reduce, though. I mean, I would argue that despite this directive, this doesn't reduce the harm of your encounter with the police in the first place, because people are still getting charged, and that is harmful in itself because you get known to police. There's a stigma associated with police involvement, and there's a record of that encounter, but it does mean that people aren't getting charged as much as they were before. So then I talked about the local request for exemption, and we know of 3. The first one that came out of the gate was in Vancouver, November, 2 years ago now. Vancouver City Council adopted the motion for the mayor to request a federal exemption. Vancouver submitted its proposal in May 2021, but that got eventually subsumed by the BC request. So here's the then mayor, Kennedy Stewart, and here's the Minister of Mental Health and Addiction in BC, Sheila Malcolmson. BC requested an exemption in February 2021. That was to decriminalize a number of substances, so not all substances in the entire province of BC. And they came up with a cumulative threshold of 2.5 grams. That means for a number of substances, including some opioids, methamphetamines, and some psychedelics, that they would, like all of them combined cannot exceed 2.5 grams threshold. Otherwise, you would be considered to be possibly not possessing for personal use. You'd be possessing for trafficking. So that threshold is really important because the lower you go, it means it captures more people. And I know a lot of people who use drugs who are part of this BC core planning table, that's what they called it in BC, were very concerned and upset by this cumulative threshold because they said it's really too low. It doesn't reflect the patterns of use. It especially doesn't reflect patterns of use for people in rural and remote communities who might possess in greater quantities because they don't want to constantly be out there and buying from their supplier. And so in any event, this is the first, it's historic, it's a step forward, and this exemption will start in January 31st, 2023, or 2023, yes, and run for 3 years. So that's a BC request. And then here more locally, there's the Toronto Board of Health I'm here in Toronto, directed our Medical Officer of Health, Dr. Davila, to convene a working group to develop, again, an exemption in Toronto. The exemption was a preliminary request was submitted in January 2022, and that is still being refined as we speak. But I'm on this working group that has been convened, and the latest that I understand it applies to all substances. It's not like the BC one where there's 4 categories of substances. It applies to all people, not, in the BC exemption, it was youth were excluded. And it hopefully it will be a more progressive and bolder vision of decriminalization than the one in BC, which has been the cause of quite a bit of concern amongst people who use drugs in particular. So then another partial decriminalization de facto, what I call de facto, it's not full decriminalization, is Bill C5. It's before the Senate right now. It's actually in the Senate Committee on Legal and Constitutional Affairs. That means it's gone through the House and it went up to Senate, and people are actually providing testimony right now about various versions of this, about this version of the bill. So it has some principles that says problematic substance use should be addressed primarily as a health and social issue, that criminal sanctions for simple possession can increase stigma. So it's recognizing all these things. And then instead of fully repealing Section 4 of the CDSA, it's a diversion bill. So it says police can take no further action, issue a warning, or refer someone voluntarily to a program, agency, or other service provider. So it stops short of full decriminalization. That's why I call it de facto decriminalization, because I think in practice, it'll probably mean fewer people are charged, but it's still not good enough. It doesn't call for full repeal of Section 4, despite recognizing all these problems with criminalizing people who use drugs. And then just a second way that you can get to de jure criminalization, which means an actual change in the law, is through federal law reform, like a bill that actually decriminalizes. And we saw one, MP Gord Johns out in BC introduced a bill a few months ago, and it died. I didn't get to even a review at the House before the House committee. There weren't enough votes. I can't remember it was a couple months ago that Gord John's bill was, I think it was 216 was a bill number. And that was a full repeal of Section 4, and it was a better bill, but there wasn't enough support in the House for this. And, courts have also struck down laws that criminalize simple drug possession around the world. So most of them in South America, we've seen Mexico, Chile, Spain, Colombia, Argentina strike down these laws. The last time it's considered in Canada was in 2003 in a case called Malmo Levine involving marijuana activist. And at the time, the Supreme Court of Canada upheld the law and said it was open to Parliament to criminalize. It's a policy decision, but 20 years have passed and a lot has changed, and we can argue that there is far more justification today to strike down those laws as doing nothing for public health or public safety, and not in line with the objectives of the Controlled Drugs and Substances Act, which are for public health and public safety. And I'll just wrap up to say that the Canadian Association of People Who Use Drugs are suing the government. They launched a lawsuit in August 2021 on International Overdose Awareness Day, asserting that the laws criminalizing simple possession and necessity trafficking are contrary to our charter and the constitutional rights of people who use drugs. And so we'll see how this case winds its way up, because I think obviously the landscape has shifted since 2003 when the courts last considered this. That's the end of my presentation. Thank you, Arino, for inviting me to speak.
Well, Sandra, thank you so much for taking time out of your day to come and talk about that legal context, which is so important. So many issues arise in response to calls for decriminalization, the simple possession versus trafficking distinction, which is critical to the discussion. And the other one that keeps coming back at us is it's a federal issue, not a local issue, blah, blah, blah. But when we talk about CDSA and Section 56, we understand that it's federal legislation, sure, but built for local engagement when that there are exemptions there that where the interest is local, that applications can go in and be granted. And that's why we're pressing on municipalities here in Toronto, not Toronto, Ontario, to move on requests for exemptions locally. So thank you so much. I want to introduce our next guest, Mish. I went originally to Emmett Riley, who many of you may know, an NP working in harm reduction, safe supply here in Toronto, and he said I got a full clinical day on Monday, but one of my colleagues has great enthusiasm for this issue. I said, well, I'm sold. Great enthusiasm then is what we want, and so I got in touch with Mish and so appreciate her willingness to come and talk about her practice here in Toronto as an NP, and how decriminalization intersects with that practice. So Mish, can I turn it over to you, please?
Yeah, thank you very much. And thank you for inviting me. And thank you, Cori and Kathy, very much for sharing your stories and all of the excellent information, Sandra. I still always have much more to learn from the legal perspective. But I will talk to you today a little bit about the work that I do and the harm reduction approaches that we're using here in Toronto, as well as some of the health effects that we see as a result of criminalization and what we really envision to happen for folks after decriminalization. So yeah, I'm Mish Braxton. I'm a nurse practitioner. I'm also a clinical lead for the Parkdale Queen West Safer Opioid Supply Program in downtown Toronto. And I'll talk a little bit about what that entails. The first thing I want to talk about is what is this crisis? Often we're talking about this as the drug overdose crisis, and overdose is certainly a part of it, but we need to be talking about the drug poisoning crisis and the issue with the actual supply that we see on the street. This chart here shows results of drug checking services in Toronto over a 1-year period of samples submitted of fentanyl and what was found in the fentanyl supply from these samples. So we can see that, you know, some of these samples aren't even testing positive for fentanyl. That's variable in itself. But as well, we're also seeing carfentanil and increasingly over the last couple of years, contamination with different types of benzodiazepines, most of which are actually not used in any medical settings at this point. In addition to, you know, the fentanyl crisis itself, we're now seeing further complications from use of this unregulated supply when it contains these benzodiazepines, because although we have tools at our disposal for reversing opioids, we don't have the same things for benzodiazepines. And the risks of overdose when you're mixing multiple substances just increases. As well, you know, we have people who are not intentionally using any benzodiazepines or don't know they're using benzos. And then when they are withdrawing from opioids, are actually experiencing benzodiazepine withdrawal as well, which can be complicated by seizures and death. So what is safer supply? Safer supply as a concept came from the community of people who use drugs. The Canadian Association of People Who Use Drugs put out this framework in 2019, suggesting how this could be brought in a medical model. So safe supply refers to a legal and regulated supply of drugs with mind or body altering properties that traditionally have been accessible only through the illicit drug market. So with the medicalized safer supply programs at this point, the main methods that we're using are to provide people with hydromorphone or Dilaudid tablets that people can choose to use in whatever form that they wish in order to help them reduce their use or their reliance on the contaminated drug supply. Some of the goals are to reduce the risks of overdose and overdose death by providing this safe supply. To reduce the harms that are associated with criminalized activities required to access drugs, and to increase access for people who face barriers to accessing traditional models of healthcare, harm reduction, and social services. And I'll certainly talk more as well about how these barriers are created for people who use drugs within our system. And I'm lucky to at least work within a team where not only are we providing people with a safe supply, but we are also providing wraparound supports, whether that's nursing, case management, and counseling. I want to mention also about depathologizing substance use, because we need to be recognizing that substance use does exist on this wide spectrum. I think most of us understand that, you know, alcohol use, for example, does range in what that represents to people, whether that's pathological use, something that's negative to them, versus I think many of us in this room probably use alcohol in non-problematic ways, probably use it socially. And all substances are also used in this way. There's not some substances that are only pathological. There is social use of all of these substances. And when we talk about decriminalization, we need to be considering all the people that are affected by this, and not just framing this as a health issue and always around addiction and dependence, but also as human rights and freedom to pursue different activities, as you will. Just to drive this point home, I like to bring up this chart here, which shows people who have used these substances 2 years ago, about what percentage of people would meet the criteria 2 years later for problematic use or substance use disorders. So even for things that we consider to be quote unquote hard drugs like heroin, crack, people are using these substances in different ways, including non-problematic ways. So I just want people to keep that in mind when we have folks who use drugs and they're coming to us, that not every person is coming with a substance use disorder that also requires treatment, although we do need to be improving access to that as well. This is part of destigmatizing use as well, and ensuring that we have these open lines of communication with our patients. Health-related harms of criminalization. Criminalization promotes unsafe consumption. It promotes people using in isolation, which of course increases the risk of overdose. It limits people's ability to obtain clean injection supplies. It also causes people to use in other unsafe ways, such as trying to use really quickly to avoid detection, which means that people may not be able to employ the infection control techniques that they would otherwise use, or they may be trying to inject so quickly that they're missing their veins, which leads to abscesses and other complications. Definitely criminalization contributes to stigmatization. And we see this structurally, we see this socially, and it also comes out internally in people who use drugs. Stigma produces alienation from healthcare, and also limits how our resources are distributed to harm reduction and treatment, such as safe injection sites or drug checking services. We often talk about criminalization and its structural effects, which are definitely present, but I always also like to bring it down to this level that incarceration is directly linked to an increased risk of death from drug toxicity. This one study that was looking at Ontario data from 2016 to 2013 to 2016, 1 in 10 drug toxicity deaths occurred within a year of incarceration, and 20% of these deaths occurred within a week of release. People are 12 times more likely to die of drug toxicity if they were recently incarcerated. So we can definitely look at the ripple down effects and the effects of incarceration, you know, on someone's the rest of their life, and how that puts them at risk. But just being incarcerated itself is one of the highest risk periods for people who use drugs to experiencing a drug toxicity death. And it's certainly one where when our patients are incarcerated, we're very worried when they come out. Factors around this, definitely loss of tolerance during incarceration, and a severe lack of access to treatment and harm reduction resources within our carceral system. This one survey of correctional facility physicians in Ontario in 2018 showed that only 23% of them were initiating opiate agonist therapy to people while incarcerated. And that includes things like methadone, Suboxone, et cetera. So, you know, sometimes people like to position criminalization and being incarcerated as this, you know, captive moment to engage people in treatment or in harm reduction. But unfortunately, even in these circumstances, we have very little resources that are occurring. And then there are also post-incarceration stressors that do contribute to use. Overdose deaths in healthcare. There was this recent report that came out of the Ontario Coroner's Office of recent healthcare encounters prior to opioid-related deaths. So nearly 30% of people who died of an opioid overdose during March to December of 2020 during the pandemic had healthcare contact in the last 7 days. I mean, particularly extraordinary given how reduced healthcare contact actually was during the pandemic. And why are people dying of a drug toxicity death after they've just engaged in healthcare? Whether this is a missed opportunity for harm reduction, for connecting people to treatment, or actually introducing healthcare-related harms to this population. The alienation and discrimination from within the healthcare system. The folks that I work with are terrified, absolutely terrified to go to the hospital. And they understand the risks. It's not a matter of not understanding that, you know, chest pain and a heart attack means you need medical attention, or, you know, we've seen people with such severe infections that they've fainted at home multiple days, but their experiences, unfortunately, at the hands of healthcare workers has been so poor that they would rather take those risks than to engage with our healthcare system. And decriminalization, you know, will contribute to reducing the stigmas associated. I did want to take this moment with a captive audience to stress that we really need to be looking at our own behaviors and how we're contributing to this. And this is to the extent that there's an increased risk of overdose in the period 1 to 2 weeks after hospital discharge. The risk is actually higher than prior to accessing healthcare. And again, this happens for similar reasons to incarceration, that unfortunately, there's such a lag time in having people's, even if people are receiving methadone or they're receiving safe supply, they're on a treatment in the community, getting that treatment continued when people are hospitalized is very difficult. And there's often big delays in that. And then people lose their tolerance. Or, you know, having this abstinence only approach and insisting that people can only manage their withdrawal through things like methadone or Suboxone and cannot continue their usual use while in hospital means that people are losing their tolerance and are vulnerable to overdose upon discharge. So a few things about caring for people who use drugs when they are hospitalized. We need to be promoting culturally safe care for people who use drugs, challenging our beliefs and behaviors towards people who use drugs, promoting rapid access to withdrawal management, both with things like methadone and Suboxone, but offering short-acting opioids to treat withdrawal. You know, often I have someone who's gone to the hospital and their withdrawal could really be managed with some morphine, could be managed with Dilaudid. It's not, you know, they're not interested in starting methadone. And that medication would keep someone comfortable and well enough to be staying there and receiving critical medical attention. But our attitude has often been, if someone has a substance use disorder, that we're not going to provide them with any opioids because it is going to worsen their addiction. But there's just not evidence to that. And, you know, denying people that care is leading people to leave the hospital without that medical attention. And we see this again and again with our clients, whether it's leaving with MRSA, bacteremia, septic, but so uncomfortable that they physically can't stay, and no one is providing them the care to facilitate that. Abolishing abstinence-only policies in hospitals. I recently had someone who was hospitalized and discharged because they had left the floor too many times because they were using, and were hospitalized for a injection-related infection. And then incorporating harm reduction into acute care to support wellness during hospitalization. So providing sterile injection equipment, incorporating supervised consumption sites or supervised consumption practices into acute care, and then providing people with take-home naloxone. This has been my recent little pet peeve, is this idea of people leaving against medical advice. So often, my patients are being discharged under this title of leaving against medical advice. And when I talk to them, they understand the repercussions of leaving and they want to receive that treatment, but they want to be able to stay. And I want all of us to be thinking about whether these people are leaving against medical advice or whether they're leaving due to inadequate healthcare. So decriminalization, how that links back to all of this, we need to abolish stigma, and certainly criminalization is such a big promoter of this. Reducing structural inequities in access to health and healthcare, and decreasing the exposure to periods of high risk for drug toxicity, such as during incarceration. Thank you very much.
Thank you so much, Mish. That was a presentation full of so many kind of invitations to shift our perspective on this issue. Everything from depathologizing as a form of destigmatization, the risk, the direct risk of incarceration as a new issue you brought to the table, which was fascinating, the data there. And of course, the risk actually of being in the healthcare system to people who use drugs, and what that means. All things that we in our policy department at RNAO need to keep at the front of our minds as we pursue these issues. So thank you very much. Emily, are you out there? Emily, also an NP practicing in Toronto, and is going to bring her clinical perspective to us. Emily, can I hand it over to you, please?
Absolutely.
Thank you.
Hi. Hi. So I'm Emily. I'm kind of feeling lucky. It's a tough act to follow, but a lot of the stuff was said. Yes, absolutely. I agree to all of the above. And thank you so much, Cori and Kathy, for sharing those stories. I was biting the inside of my cheek not to bawl my eyes out on camera. And yeah, like I said, it's a tough act to follow. And I'm also kind of the rebel NP, because I don't have slides and I'm owning to, like, I'm committed to this. So I work at The Works, which is through Toronto Public Health. And I work in the IO program. So The Works, just in case some don't know, it's harm reduction based program. It's been around since the 80s. There's a bunch of programs offered out of The Works. One of which is supervised consumption site, but there's needle exchange, outreach, nursing services, counseling, et cetera, et cetera. And about a year ago, or a little bit of, over a year ago, we opened an IOT program, so injectable opioid agonist therapy. It kind of comes between the safer supply and the treatment. So basically what it is, the folks that I see in the IO program are people who use IV drugs. And the goal, or actually that's basically the only criteria, is using IV fentanyl. When people start with us, they don't have to be on traditional OAT programs, so opioid agonist therapy like methadone or Suboxone, or slow release oral morphine like Cadian. And they don't have to stop their fentanyl use. The goal of it is to offer injectable option that is safer than the street fent. So right now what we offer is the injectable hydromorphone. So it's not the tablets like the safer supply. We can't do any take homes or carries. So that's in the sense where it's a little bit closer to a treatment program, because people do come in the program space. We have nurses and counselors on site. They'll be offered needle that's prepped with the amount of hydromorphone that's been prescribed to them. And they get help with either if they want to inject themselves IV, if they want support in an intramuscular injection. And then we take that time to discuss with them, vein health and all kinds of stuff like that. So basically, when people start with the treatment, we take them where they're at, and we see what suits them for the treatment of what they want. So basically, besides the hydromorphone, I also offer other options. So a lot of the folks I will offer if they want to start also on a more traditional OAT. So since the hydromorphone is short acting, it's good to make sure that they don't go into withdrawal in between doses. And so I'll start them on methadone and Cadian, whatever they decide. And then I can also offer other options to help with cravings if they have other if they use other substances. I'll go through what's possible for me to offer. I also offer wound care, sexual health care, and informally, so I offer primary health care. So it's not within my role, but as a nurse practitioner, I can't really dissociate substance use from the rest of the person and what's going on with them. So one of the things that I do try to do is to connect people, to refer them to primary health care, to try and do a warm handover as much as I can, because we know that these folks don't want to access healthcare. It's difficult for them to access. The fact that with this program, I've actually been able to start the conversation with different organizations. We're in connection with St. Mike's. They're aware of what we do, and they want to discuss how they can support our clients. If the person that I'm seeing, if my client has a health issue that I can't necessarily deal with right here, right now, what I will do is I'll make an assessment, I'll write a consult note, and I'll send them to Emerge, which it's difficult. People don't want to go. They have bad experience. We've proven to them that it's difficult for them to access healthcare. The fact that we have like a more official program, we're able to start the conversation. I've docs from CAMH call me and be like, oh, hey, this person is here for so-and-so, like, what do you think? How can we help this person so that they will stay in program? How can we work with you? And we don't have full solutions yet, but we're working. I think the door is open for some conversation there, which is great and needs to continue. And I also help some folks just keep up with specialist appointments because it's hard to keep up, or just answer questions, things like that. Now, when it comes to criminalization of substances and decriminalizing, so we know, and people before me have shown how this creates a barrier to accessing healthcare. I was actually reading an article recently that was saying that in Ontario, they looked at family physicians They were actually almost 3 times less likely to offer intake appointments to patients with opioid use disorder. And another thing that people experience as well in Emerge, which was explained, it's diagnosis overshadowing. It's having the person wait a little bit longer just in case they leave before we have to see them. So before they leave AMA, it's contributing to that, right? Especially if we know if that person has a history of substance use disorder, they're drug seeking. So let's just, no, I can't give you any opioids, you're drug seeking. Having programs like Safer Supply, having programs like IOT that can collaborate with hospital, with emergency rooms, like I'm hoping that that can help move us away from the stigma, help offer folks better care, actually, offer actual transition of care, right? Because drugs are criminalized, drugs are considered bad, and people who use drugs are bad. Having drug charges on your criminal records makes everything worse. It makes it harder for you to get a job. It makes it harder to have Toronto, but also Ontario, it makes it harder to have housing. And all of those, we know it's in the literature, all these contribute to poor health, but also higher needs for healthcare and lesser access to healthcare. So it's not only that you have more needs, it's that those needs are have less chances of being answered because of the stigmatization that comes with it, because of the diagnosis overshadowing, because there's so many people needing an MRP, a primary care provider. Why would we see the person who has an opioid use disorder or just any substance use disorder? And so by decriminalizing, the hope is to move away from the stigma. I think it's just a start of the conversation. I don't think it's the end. I think we need to continue on that track and continue denouncing the stigma. If we look at places who have decriminalized, if we look at Portugal, who decriminalized in 2001, they've actually decriminalized personal drug supply for up to 10 days. And they were afraid of increased drug tourism. They were afraid of seeing more overdoses, seeing more issues, but actually they've seen an improvement in drug-related social issues. They've seen an improvement in drug-caused mortalities and drug-related illness transmission, so HIV, hepatitis C. They've seen improvement in those, but also people reported that it was easier for them to access treatment because the fact that it was decriminalized was less stressful for them to risk being arrested if they were talking about their substance use. Some of the numbers, some of the things that we've seen with the IOT program, and these are just preliminary and they're still ongoing, right? This is still a very young program. Although in Europe, since the early 2000s, there's several countries that have been using IOT, hydromorphone, but also heroin. We just have the hydromorphone for now. But some preliminary numbers that we can see just from our program is, so clients, when they started on the program, so 52% of those folks were already on OAT, so methadone or Suboxone and or Cadian. This number increased to 97% by the time those folks were through with our program. By the time they stopped using the program. So that's a huge number, right? It shows that adding the IOT can help the person get stabilized on a treatment. Also, okay, a lot of folks, when they came into the program, they already had a OHIT number, which is good. 70% of them had an OHIT number. But that number actually increased to 88%. No OHIT number makes it really hard to access care and access medication. It's a huge barrier. another number, 22% improved their housing while they were on the program, which is good. Having access to counselors, having access to support, not having to spend their time looking for drugs, looking to make money to buy the drugs, etc. Mean that 22% were able to improve their housing. And there was 50% fewer clients sleeping outside. We know that our shelter systems are full. We know that it's hard to get a bed, let alone housing. 50%, half the folks were able to get a bed somewhere, whether through housing, whether through the hotel programs, whether through shelter. But that's a big improvement. Also, when people were at their stable dose, where they were comfortable, 60.5% of those clients reporting using no more street fentanyl, which is a good number. I know that we'd like to see 100%. I'm kind of curious to see how those numbers will evolve as we go. Now, like I said, it's still a very young program. Some of the hopes for the future is to be able to offer more than just the hydromorphone. We are working on a new, on a different medication to prescribe, sufentanil, which is stronger than hydromorphone. Also, this can be used as a second line, although iode is already third or fourth line, so I'm not sure what line we're at, but we can use this for people who don't tolerate the side effects for the hydromorphone, or who needs higher doses than what we can give for hydromorphone. And these are very high doses, right? People can come up to twice a day to use, and it's up to 200 milligrams of hydromorphone per injection. This is a big number. And so for sufentanil, for people where the hydromorphone doesn't touch them as much, they need more, or who, they don't tolerate the side effect. And one of the hopes, so we talk a lot about injection. There's no smoking consumption site or supervised smoking sites in Toronto, Ontario. And these are also folks that are dying from overdoses, right? There's no safe space for them to use the same way that there is for injection. So one of the hopes that we have in the program is that sufentanil is actually available as a sublingual, or can be used as a sublingual. So fingers crossed, we'll be able down the road to offer that as an option for those people. And that's about it. I know it's just the one program. We're very little, although it's been proven. There's data coming from Europe, coming from BC. It works. So let's hope that we get continued funding and we're able to offer this program to more people, the same as, on the spectrum as Safer Supply, as Oats, as all the other options to address the person's needs,
Thank you so much, Emily. With respect to that funding issue, I hope you'll always come back to RNAO when those sorts of things are needed for us to support the work that you do. A quick thanks for the lovely art in the background as opposed to the slideshow, and that's always welcome too. And finally, thank you very much for pounding home for us this important issue about the effect of stigmatization that flows from criminalization, and all the implications of stigma on access to care. And also, I mean, in my role at RNAO, our department is consumed with public policy issues, but I think you've got a foot both in what I do call kind of clinical policy issues and public policy issues by kind of reinforcing what Mish was talking about, this issue of stigma within the healthcare system. And I think that's such an important complementary point to the public policy issues that we're trying to bring forward for this audience that has joined us today for this webinar. So thank you very much. And with all of that, I'm going to bow out from a speaking role and pass it over to Sabrina, my colleague, to facilitate a question and answer for the remainder of our time together this afternoon.
Perfect. Thank you, Matt. And thank you to all of our panelists for joining us today and speaking with us. I'm going to take us through some resources for support and the resources that we have with the RNAO mental health and addiction portfolio. So start thinking of some questions that we can talk to our participants and our panelists today. That would be fantastic. As you're aware, we've heard some very heavy conversations today and some very heavy topics today, and we want to make sure that you and or your family members are well supported. If you are in a crisis currently and need support, please either call your local distress center or 911 for some support. We will put in the chat box some other support such as Connects Ontario, which provides up-to-date mental health information 24/7, either by phone, chat, email, text, as well as the Nurses Health Program, which is a voluntary program for Ontario nurses designed to encourage to seek treatment for substance use and or mental health issues. So my name is Sabrina. I'm the program manager for the Mental Health and Addiction portfolio, and it's my pleasure to be here with you today. The RNAO Mental Health and Addiction Best Practice Program was established in 2006. And if we can flip to the next slide, please. The goal of the program really is to help support nurses and healthcare providers in enhancing evidence-based services related to mental health and addictions to support the people that you work with on a daily basis so that no door is the wrong door. We do have access to mental health and substance use best practice guidelines. We have a variety of e-learning modules that are available for your use, as well as monthly webinars. And videos, whether it's talking about stigma, whether it's looking at how do I do motivational interviewing or brief intervention, or what are the types of substances that people use and how can I get more information on that? You will find them there as well. And we do have toolkits as well to support you working with youth, as well as working with nursing students and nurses that need more support with our educator resource guide. And you can find more information on the link below, or please feel free to contact me. So at this time, I'd like to open up the panelists and open up for question and answers. And I know, Kathy, you've had your hand up for a little bit. So how about I unmute your line and you can go ahead and ask your question.
Actually, I wasn't going to ask a question. I just wanted to give a fact that we hadn't brought up in the discussions. And that is, I don't think, I mean, I have to imagine that everyone that's on this call is here because they want to prevent the deaths and suffering that are going on. But if you can't do that when you're talking to politicians, you might want to point out the fact that the latest figures that I could find from 2017 suggest that our country is spending $6.4 billion on the policing, courts, and correctional costs associated with criminalized substances. $6.4 billion. That's in 2017. So I'd imagine that there's been a huge increase in those costs. And what happened in Portugal was that much of that money that was being siphoned into the criminal justice system was actually then siphoned into housing, job creation, accessing issues for mental health services and things like that. And that's part of what Portugal's success was. So I think it's just important to be able to bring that, and you can get those figures from the Canadian Drug Policy Coalition and their documents available online, and I'll put the link for that. So I don't have any questions per se. I think the other members really brought forward a lot of those things, but I often say if politicians can't do it for the human factor, then look at the money factor.
Perfect. I noticed Matthew just put in the Canadian Substance Cost and Harms article in the chat as well. Yeah, Mish.
I did also want to mention that unfortunately the safe supply programs that are running in Toronto, and correct me if I'm wrong, but I believe the IOT program is currently funded by Health Canada. This is not a intervention that the Ontario government has chosen to fund at this point. So this is definitely something that we need to be advocating for our province to take accountability for, because it's part of our healthcare.
Absolutely. Absolutely. And Matthew.
Just kind of building on Kathy's point a moment ago around the cost of it to when we start to look at the overall cost, and when it comes to opioids in particular, the largest contributing cost factor is lost productivity. Now, in lost productivity, that includes mortality. So it's just sort of, if we're keeping people alive, if we're able to help support them, at the end of the day, we're supporting them and being more productive. I don't want to necessarily more productive, but I'm sorry, I mean, I have a bit of a brain fart right now, ADHD moment. But we're keeping people alive at the end of the day, and we're reducing those overall societal costs. It's just, yeah, that's it. Sorry.
No, thank you for adding that. That's really important to remember. I think one thing I got from the panelists as well is that these are people, right? These are our family members, they're our loved ones, they're people we work with on a daily basis, and we have to remember that. Absolutely.
I have a question, but I don't know how to raise my hand.
No, go ahead. You've raised your hand. Thank you.
My name's Ashley Steves. I'm a registered nurse, and I work for the Opioid Outreach and Treatment Services with Halton Region, and I have been there for the last 10 years. I'm also in the last year of my nurse practitioner program, and certainly through working in Halton, as well as proudly having my own story, I have decided to, pending one final conversation to make sure I know what to expect in the role, gladly accept a position as president of the RNAO for the Halton chapter. And a big part of why I want to do that is to help, help talk more in the nursing community, especially in Halton, about what we go through with addiction, particularly with benzos, because it's like this underdog to opiates that just doesn't get discussed a lot. There's no detox in Halton. There's very few benzodiazepine withdrawal options. Of course, like you're saying, the supply is tainted with benzos, or people can't get the benzos because, they're being treated by a physician. The second they say, I don't feel well when I stop taking this, I've seen people be tapered at 50% or stop prescribing altogether. And then they're going to street benzo use, which is of course tainted with fentanyl. So in stepping into my role, I'd really like to do something like what you've done here today, but perhaps to talk a bit more about benzos and the problem that causes, and how hopefully when I'm finished my NP, I'd like to be part of a larger conversation or a proposal for funding to do, a safer supply program here or a detox here. So my point is, would Emily or Mish consider accepting me for shadowing for a day at your facilities? Because what you're doing is I just look at you right now as a novice NP in total awe.
Absolutely. I love taking folks to shadow and spread this. I'll also put in the chat just the link to the National Safer Opioid Supply Community of Practice, where there are regular meetings as well as supports for other prescribers or clinicians, and a number of resources there as well.
Thank you so much.
I absolutely am also very happy to have you come and shadow. Benzos are another issue that we see, and they are difficult to treat. And like Mish showed in her slides, yes, people do go into withdrawal even if it's not their drug of choice. It is something that we do have to monitor. And having people get ongoing treatment or even like a slow tapering is really difficult to access. And a lot of prescribers are not comfortable with that for many different reasons. But yeah, it is a very it is a big issue. We do talk a lot about opioids, but there's not that many resources for benzos, but also for stimulants as well is another thing where treatments are. We need more data. We need more options. But we can definitely. I'm guessing Sabrina can definitely put you in contact with me. So yeah.
Absolutely, Ashley. We can absolutely put you in contact. I will reach out to you and then we can connect you together.
Great. Thank you so much. This was amazing. And I know that, sorry to embarrass you to our peer support worker, but there is an ADAPT peer support worker on here. So I'm really proud to start expanding RNAO, what they have to offer to the ADAPT outpatient addictions community.
It's fantastic, Ashley. And welcome to your role in the Halton chapter.
Thank you.
There's a question from Brandon. Is the panel hopeful that decriminalization can also facilitate easier development and rollout of drug checking technology? A tested and regulated street supply could serve as a complement to a safe supply program. Are there any thoughts on that?
I don't want to take up too much space.
Go ahead.
I would think that, you know, the decriminalization is one aspect, but then we need to also be talking about regulation and being able to have a regulated safe supply. The issues with placing safe supply within a medical realm is, number one, you know, I don't go to my doctor to ask how much alcohol I can drink. People are often able to regulate their own use in safe ways if we provide them with access to a safe supply. And there are groups who are looking to create different models, non-medicalized safer supply models. I would point to the work of people like DULF, DULF, the Drug Users Liberation Front in BC, who are looking at other models of care. And especially with the medicalized model, we are so restricted by funding and resources that we're only able to extend it to a small number of people. So decriminalization certainly would be helpful for people to be able to access drug checking programs, but it's sort of a smaller step on getting a broader access to safe supply.
Perfect. Thank you, Mish. Do any of the other panelists want to respond or?
So there is the drug checking services offered in Ontario in different, safe consumption sites. I do hope that there would be a better, like a possibility to monitor and to offer safer substances, because not everybody is interested in stopping their substance use, which is part of the spectrum. But yeah, I think maybe more than decriminalization could be good, because it's the supply chain as well, right? It's not just people with their own personal supply. It's where do those substances come from, and like we've seen, there was more, like there's more toxicity, and COVID did not help, and why is this? Is it because the borders were closed and nothing came in? Is it because? So I think it's a discussion that needs to happen, and that, you know, decriminalization is just one step in that sense. Yeah.
Perfect. Thank you. Kathy, did you have something to add?
Yeah, I think drug testing is really important, that it be accessible, and part of the limitations as well, where we all have to continue to advocate, is there's only 19 of the 23 promised CTS sites in this province, and they're not accessible to a lot of people in the north. And CTS sites is usually where drug testing takes place, and they're not open 24 hours a day, and because there's not the funding for that. And so, I mean, we've got a limited number of people who use drugs who can avail themselves to drug testing abilities. So it's again, it's a resource issue, and our provincial government believes that treatment is the only option for people who use drugs. And that's why they've committed an entire couple of $1 million to opening new treatment beds that have no staffing, but that's a whole other topic, that won't have staffing in our abstinence space, which we really know don't work well. So it's you can't look at any one issue in substance use and this whole problem, decriminalization being one part of it, without having to look at the others. Because if you solve one issue, there's a whole bunch of other issues that have to happen concurrently. It's kind of like I'm a cancer nurse, right? So if I think there's one agent that works on a certain part of the cancer, if I don't give the other agents, it doesn't really matter because I'm not going to have an effective outcome. So I think it's a huge issue that we continue to need to advocate for, because you can decriminalize, which will make people more comfortable coming to get tested, their drugs tested, but it may not, if that's not accessible, they're not going to, it's not going to work.
Perfect, thank you. Before we get to the two next questions from Jordan and Dr. Holloway, we do have 2 polls to run right now. And Susan or Olivia, if you could please put them up.
I think Olivia is going to pull them up and just want to thank Kathy for her suggestion to run these polls. I think that to put them up now would be timely.
Thank you.
Kyle, if you can just confirm for me that you can see the polls. There we go, we have some voting.
For the second question, you might just need to scroll down to see that there are 3 options. Yes, no, I'm not sure. Okay, Sabrina, you're not able to see the polls, I don't think,
No,
but
no, I can't. As long as
okay.
everyone's doing them, it's fine.
Yeah, so I'm able to see them. And for the first question, how comfortable are you with the idea of decriminalizing personal possession? We have 76% are very comfortable, 21% are somewhat comfortable, and 3% are not comfortable. And for the second question, do you think your practice area would support decriminalization and other harm reduction strategies? 65% say yes, 3% say no, and 32% say not sure.
Perfect, thank you, Susan. I will read out Jordan's question next for our panelist. Jordan says, thank you so much for sharing your knowledge and stories today. I wonder if Mish or Emily could speak to this at all on how their organization and how they as clinicians address any potential stigma of the not in my backyard attitudes and prejudices where your IOT or safer supply work are situated.
Mm.
Who would like to go first?
I can speak to that. So being a big organization with a very public, within a very public organization, it is something that is very often discussed and can cause a lot of issues. We do outreach, so the Works has a lot of different types of outreach. So obviously outreach, the aim is to get folks that don't necessarily access services for whatever reason, because they're not comfortable coming in or anything like that. But part of it is also to be seen in the community and to go and meet other people in the community that have a backyard, basically, and to just hear them out and also maybe help support them in different things, picking up needles and things like that. it's not 100%. It's always a work in progress. There has, and I'm so sorry, I cannot say where the numbers are, and these might also be partially from, I'm originally from Montreal, and this was also a huge issue. But when services withdraw from communities, there's normally more issues afterwards, when the service is. So actually, this is very probably from Montreal. So Cactus is a big needle exchange, and they have supervised injection sites. And when they moved the neighborhood where they were in the first place, after Cactus moved, then they were seeing more issues. So Cactus was actually helping with by doing this outreach, by being there to support people. So it's ongoing education, connecting with people, and yeah.
Perfect. Thanks, Emily. And Jordan, just to let you know, on the RNAO Mental Health and Addiction webpage that I presented earlier, we do have a video that you can show your colleagues of an NP with a client with lived experience of a person who uses drugs, talking about stigma, exactly that, and how can you work with your colleagues and your organization to combat stigma. So that's something else that you can look at too. Dr. Holloway, I'll turn to you.
So good afternoon, everyone. Claudette here, President of RNAO. And thank you, Kathy and Cori, for sharing your stories. I had opportunity during the Decriminalize Now campaign to speak to, I think, 9 radio stations and 1 TV station. So thank you, Matt and your team, for the information that you provided. Certainly, there's so much more for me to learn. And I have one tomorrow. So I feel much better prepared. And I also want to say to Emily that I'm a past member of Toronto Public Health. So I remember when the work started and all the, the harm reduction work. So I was already sold on harm reduction. I know about it for the 30 years that I spent in public health. So I just want to encourage you all. One of the questions that are coming up for me tomorrow, you may be able to help me with it. What what is your experience? Is there any particular points you want to bring forward about what you're experiencing, what you desire more of in the work that you're doing with the clients that you're working with?
Yeah, I can speak to that. I think one of the things that our Canadian Health Minister had pointed out that in order to expand access to harm reduction services and to safer supply specifically, we need clinicians and prescribers to feel comfortable to be able to do this work. And we've tried to connect with our regulatory colleges. The CPSO luckily has put out a statement, maybe in lukewarm support, but at least acknowledging safe supply and that there is evidence behind it and providing some guidance in the practice. But as I mentor new prescribers, often the questions are around regulation of nurses and being persecuted for doing this work. So what I really want to see is statements from our professional associations and from our regulatory colleges that provide reassurance about the work that we're doing. Because so often that's the voice in the back of the head is what happens when I'm audited, even if you believe in what you're doing. I think it would also help with access when our patients are unfortunately hospitalized and they've been stabilized on a treatment for maybe months or even years. And then when they are admitted to hospital, the provider there is not comfortable with continuing the care that they've been stabilized on. And if we were able to point to these resources and supportive statements, our patients would be able to continue to receive this care and not be at such a high risk.
Fantastic, thank you. There's such an amazing amount of questions. We have one more left, and I think this really summarizes the conversations we've been having today. So it's from Jenna. Can anyone share how they maintain their longevity and compassion in harm reduction work? I work in a supervised consumption site and have been an RN in harm reduction for over 14 years, and I'm finding it increasingly hard to see the human behind the behavior. I've been insulted, had death threats, and managed severe violence and weapons in my work. I'm looking to leave the field, but hope that others can share how they are able to continue with this work. I acknowledge that these behaviors stem from the toxic drug stream, but as a human, it's hard to live through this. Would anyone like to respond to that?
I can say one thing.
Please.
I think nurses in harm reduction need more protection. They're often left alone or with only one other person. And certainly there is a human behind the behavior, but the behavior, having lived with it, can be very scary and potentially life-threatening. And so I believe that the CTS sites that exist and other clinics need to have protection, whether it's plainclothes security or more staffing. And I know we all know that staffing is difficult, but I think nurses should not be left alone in these situations.
Perfect. Thank you, Kathy. And Mish has put a resource in the chat box as well for you, Jenna, as well. Any of the panelists have any final comments to make on that question? No, and Jenna, thank you for bringing this to our attention. I know it must be a very hard situation to be within, and we're here for your support. So thank you to the panelists for answering that. I also want to thank all the everyone for being here today. So it's 4:03 and we've gone over our time. So one more time, I'm going to pass it over to Matthew Kelway to actually provide final comments. He thought his voice would not be heard again, but here we go. I'll send it over to you, Matt.
I thought, and you were hoping, but thank you, Sabrina. Just quickly, I'm looking forward to putting out the results of our Municipal Decriminalize Now campaign over the next couple of days. I also want to let everybody know that this will be one of the 2 issues we'll be pushing for Queen's Park on the Road, which will kick off on Wednesday, hoping that our PPANs and others members will get in to meet their MPPs to talk about the fulsome harm reduction program that we advocate for here at RNAO. I'm almost tempted to be so proud of me and my RNAO colleagues today for putting on this webinar. I learned so much, so I almost can't help be proud of what we've done. But in all things in life that we do well, I'm mindful that we're standing on the shoulders of others. And today, RNAO stood on your shoulders, Cori, Kathy, Sandra, Mish, and Emily, and thank you so much for lifting us up. I know it's not an easy task because every day in your unique ways and roles you are caring for and lifting up so many people who need your help. So our love, our thanks go out to you for your work, for sharing your stories with us, for sharing your expertise with us, and for your participation in RNAO's webinar today. Thank you very much.
Thank you.
Thanks for having me.
We got lots of work to do.
We do.
Yeah.
And we will continue.
Thank you, everybody, for participating today and listening.
Thank you.